Dr. Jodi Polaha and Dr. Robert Park. Dr. Robert Park is a professor of community and behavioral health. He is an associate dean for academic affairs here at ETSU. He is the interim chair of the Department of Biostatistics and Epidemiology. His training and education include a BS in psychology at the University of Alabama, MPH in health behavior at the University of Alabama, Ph.D. in health education and health promotion at the University of Alabama as well. He completed his fellowship at Emory University. With him, we also have, as I mentioned, Dr. Jodi Polaha. She is an associate professor here at the ETSU Department of Public Health and Department of Family Medicine. She is a director of Southern Appalachian Children's Behavioral Telehealth Clinic. Her education and training include a Bachelor of Science, Psychology and Communication at the University of Pittsburgh, Pennsylvania, a Master of Science, Clinical Psychology at Auburn University in Alabama. She also has a Doctor of Philosophy, Clinical Psychology in Auburn University in Alabama as well. Please welcome both Dr. Park and Polaha.
I think I'm on. Oh, I can hear myself. Good. Well, hi, everybody. I see, I would like to shout out a fellow psychologist, Dr. McGowan, one psychologist to another. And I think that the rest of you are psychiatry attendings and psychiatry residents. Is anyone else not from those categories here today? Can you? Wow, look at all those people that are not from that category. Are you medical students? Great. That's you, everybody? Great. PA students? Okay, good. Good for me to know who's out there. Well, Dr. Pack and I are really excited about talking to you today about dissemination and implementation research. This is a new brand of science in the medical and behavioral health and public health fields. Well, really all health professions. For a long time, it was a small kind of marginalized area of research called health services research. And this is sort of a more bona fide and growing field. So we're excited to get to tell you about it. We have no disclosures, as the slide clearly indicates. And I just want to start by saying we borrowed slides and ideas and pictures and things from some of the experts in dissemination and implementation research. Both Dr. Pack and I attended a training institute for dissemination and implementation research in health. I went last summer. He went this past summer. This is an NIH and VA-sponsored training. You have to apply for it. It's a competitive process. They choose 30 or 40 people based on your past record in terms of interest and publications and proposals developed in areas that fit with the mission of D&I science. So you get to go for a week, and it's free, and you train in this particular type of methodology. So Dr. Pack and I are bringing you that kind of knowledge, everything we gained from being at TIDER, but also we are both active D&I researchers. So we're going to bring you kind of some of the projects we're actively working on. My talk, the first half of this experience will be more about what is D&I science. And his talk, which is the second part, will be more about a very specific project that we're looking at doing in this region that engages the methods of D&I science, well, the models and methods of D&I science. So you can get a practical example. So this is me out on Max Patch, and we all, well, not all of us, I guess, but many of us who work here at ETSU and go to school here at ETSU appreciate these opportunities to get out into the hinterland, as I've come to refer to it. I am a psychologist who spent my entire career with an interest in rural health, particularly children's rural mental health, and trying to figure out how to get evidence-based treatments into rural areas. And by virtue of being rural places have a lot of barriers that make it difficult. So here I am in a rural area. I'm enjoying it a great deal, but I'm also very much appreciative of how these places make it harder for technology to be accessed. And so it's not uncommon for me to get really troubling phone calls. I don't do really much of a private practice. I don't advertise. I'm not really even credentialed with insurance companies. I don't have a place where I really see patients. And yet somehow people are finding me all of the time because it's so hard to find services in this kind of underserved area where there are so many barriers to getting good mental health care. People know I'm a pediatric psychologist, and they're kind of finding me. And it's hard to get those calls, especially when I'm not really able to provide direct services or refer them to someone who can. Many of the calls I get are kids who have specific behavior problems. In fact, this week I saw 2 kids, a 4th grader and a 5th grader. Both are refusing to go to school. They're tantruming, kicking. One broke a blood vessel in his face yesterday because he was so out of control in the car on the way to school. Vomiting. I'm getting calls from principals. I'm getting calls from teachers. I'm getting calls from parents yesterday. It was awful. I didn't get any of the work done that I planned to get done because I was dealing with kids that are really just kind of behaving poorly and getting out of control. And that's a lot of the calls I get. And so for me, a lot of what I deal with is treating behavior problems and thinking about ways to prevent behavior problems. And it's kind of nice when I can do that because psychology has a really nice armamentarium of evidence-based treatments that work for a wide range of problems. But when you look at the behavior problems in kids literature, it's especially strong. We have like 50 years of really solid research, big, good-sized, randomized controlled trials with lots of subjects in them. And they've published meta-analytic papers now of hundreds of studies of evidence-based behavior management treatments that are pretty much almost standard, that have moderate to large effect sizes. And in fact, some of the effect sizes are some of the biggest effect sizes that psychology boasts. So this is a point of pride for me. Like, if I am able to work with your child, or one of my students is able to work with your child, I feel very confident that we can deliver a treatment that's going to have a huge rate of success. And I'm really grateful that I'm going to get to help these 2 kids that I was mentioning earlier today. We have the tools to do this, and I feel confident in those tools. The problem is that even though I can deliver this tool here and then do this treatment there, there's not really been a great public health impact of psychology or the behavioral health fields over the last 50 years. We've got this, armamentarium of evidence-based strategies. We know they work, and lots of good studies show this. But in fact, they're not being accessed. They're not impacting overall public health. So if you look at the data, you see increases in conduct problems among boys over the last 25 years. Of course, you can just look at the media and see that we're not really doing too well. And then if you look at mental illness overall, you see one standard deviation increase. It's so demoralizing, right? Like, this is my life's work. And maybe I'm helping him, but in the big scheme of things, it's not making much difference. And it seems like the problem is that our science, the science side of behavioral health and psychology, hasn't really developed a complete translational bridge. I'll talk about what that means. Most of you have had exposure to type 1. Well, there's lots of different categories. I'm just using 2 of the published types that I've seen out there. Type 1 research, you've seen studies that further our basic knowledge about human behavior and how it works, studies that help us think about classifying disorders, and studies that help us think about where disorders come from and etiology. And you've also probably seen the studies I've been referring to, studies that show that we can effectively treat these problems with these kind of protocolized, evidence-based treatments. Talking about cognitive behavior therapy, or talking about lots of other things that have come out. And that's great. And this is a funny slide because it's an unfinished bridge, but the bridge kind of looks finished. But what you need to imagine is that the far right side, where it's disappearing into the distance there, doesn't quite reach the land. So we have the basic research, and we've developed the treatments, But we haven't done this second type of research, which is dissemination and implementation. We haven't actually studied, we haven't developed scientific methods around how do you get this treatment, which we know works, to actually be employed, implemented, deployed, translated, engaged, and widely dispersed on the other side of the bridge. Does that make sense to you guys? So this whole field of research that's developing that I'm talking about is a whole scientific method around that last piece of the bridge. I didn't test this out before I started, which is probably a big mistake. Oh, look, I'm going to get lucky today. So this is a little, and I'm totally probably throwing Daniel for a loop here. Do I have sound? Okay. So this is just a 3-minute slideshow that tells you about a project that we're starting. We got an interdisciplinary RDC grant last May, and so that grant is funding this study, which gives you an example of an implementation project that fits within D&I research, the spirit of D&I research.
Family Checkup has been demonstrated in really strong randomized controlled trials with lots of families in school situations. So parents coming into schools with their children to be seen in the Family Checkup. What we want to do is roll it out in a primary care clinic.
And that is what these 3 researchers from ETSU will soon do, thanks to a new grant from the school's Research and Development Committee.
The Family Checkup is a very brief parenting intervention. Most people who think of parent training think of 8 or 10 weeks and groups and lots of really commitment to coming regularly and making lots of different changes. The Family Checkup is really cool because it only asks parents to think about, well, it's an assessment that helps them know what their strengths and weaknesses are, and then it asks them to think about what 1 or 2 changes they might like to make their parenting stronger.
The study will be conducted here at Quillen ETSU Physicians Pediatrics. And Quillen pediatrician Dr. Karen Sketsina says the primary care setting is the ideal place for conversations about behavior to occur.
There have been studies demonstrating that when parents bring their children to the pediatric office, up to perhaps 25% of the time, one of the concerns that they have is about their children's behavior, and they may or may not have the opportunity or time to bring it up during each visit, but we know that it is a common concern, and it's something that we routinely screen for during child visits. I like the fact that we have the opportunity to integrate it into the primary care setting because we are a medical home for children. During the first 5 years of life, we see families 12 times for well child visits and annually after that. So it's a convenient place to address concerns about children's behavior for the parents.
From a public health perspective, epidemiological data show us that behavior problems at a young age can actually predict risk behavior during adolescence. So we want to intervene with children exhibiting behavior problems at 4 and 5 years old with the hope that we can reduce their risk of engaging in behaviors like substance use during their teenage years.
Baker says she believes the interprofessional approach of the study will result in improved community health outcomes.
Recently, we've changed the name of our Interprofessional Education Committee to the Interprofessional Education and Research Committee to encompass projects just like this one. This research project allows Dr. Polaha from psychology, Dr. Sketsina from pediatrics, and myself from public health to combine our expertise in a project we hope will be more effective than were we to go at it alone.
For ETSU University,
So the idea behind bringing the family checkup into primary care is kind of relates to this equation. And I just want to make a quick editorial comment that this is kind of a pilot study that is going to provide sort of a proof of concept for the project that Rob's going to talk about in the second part of the talk. And So that connection will be clearer as we go forward. But in any case, we have this effective treatment called the Family Checkup, and it's actually already shown some strong dissemination power. We can disseminate it through schools and get lots of kids enrolled in it, much better than perhaps some of what we did before in terms of longer specialty mental health, limited the parent training. Now we're looking at reach. We're trying to figure out, okay, we already have this effective treatment. We can reach people in schools, but we're not reaching everybody through the schools. Some people don't want their services in the schools. They feel uncomfortable. I just finished a study showing that parents feel the school is a little bit more stigmatizing. They worry about labels, especially when it comes to slightly older children. So maybe people would be a little bit more comfortable in primary care. Some people, more people, we don't know. It's an empirical question, and these are the kinds of questions that dissemination and implementation science is really kind of down with. And it's kind of by taking these effective treatments and really thinking about reach that we get at having this public health impact. So just a couple more comments about the unfinished bridge that I mentioned earlier but don't have a picture of. One thing we know is that our whole science is flawed in that it takes about 20 years for a study that shows something useful to actually be used. By the time that it gets published and by the time that people start reading it, and then the stuff that's published has to make its way into the mainstream. So as an example, I trained in graduate school, I don't even really want to talk about this, but it was about 20 years ago, and that's when Sheila Iberg was publishing her really great work on huge randomized controlled trials on parent-child interaction therapy, which is one of our strongest evidence-based treatments. And parent-child interaction therapy just made its way to our area in the last 2 or 3 years. So it took 20 years for those published studies to get here. A very good evidence-based treatment for kids with disruptive behavior problems. Another problem with this bridge, not making it to shore, is that a lot of our research is siloed, and so is our practice. And so I don't read Rob's public health journals, and I don't read any psychiatry journals, and you probably don't read any psychology journals. So whatever strides we're making in these like kind of isolated places. When Dr. Baker was talking in that slideshow about the interprofessional mission of the IPERC within the Health Sciences Center, that's really important. Unsiloing research. There's actually been some studies that have looked at the effectiveness of RO1, which is the biggest kind of study that you can get with the NIH, probably the most prestigious award that exists within the NIH. And RO1 studies are, $1 million grants that they give you. And it takes you, 5 years to do these big, giant studies. To this point, many of them have been randomized controlled trials. But the word is getting out that we maybe need to slow down on studying what works and instead take the things we've already figured out work and take them to the end point. The problem with our science is that these big RO1s get conducted, and then it turns out that only 1 or 2 of them are really usable. So they're too whatever they found that works or doesn't work, even in the best case it works, too bulky and too unfriendly in real world situations for that study, that treatment, that intervention to be deployed. Partly because of the next bullet, there's no consumer input. And then lastly, these 5-year trials, big RO1 type studies don't keep pace with technology and the healthcare evolution. You design your study, I don't know if you guys are familiar with this process, but you design your study and you write up this big, huge grant and you submit it and it gets rejected. Maybe 3 months later or 4 months later, you find this out. So you rewrite it and you submit it 3 or 4 more months later, and then 3 or 4 more months later, you find out that it's been accepted if you're super duper lucky. So now a whole year has gone by from the time that you conceived of this plan. Wait another several months to get your funds, and now you have 5 years to do the study. And by the time you finish this thing, if you initially conceived of doing like a YouTube video intervention, what do we have 6 years later? We have all these new apps and things that make your whole treatment kind of like archaic. So there are some huge problems with the way we've been doing things. This is one of my favorite studies, although I'm blanking on whose study it is. It'll come to me. They asked researchers, of the methods you use to disseminate your findings, which do you think has the greatest impact on public health? And all these researchers, put journal articles as number one, way of disseminating things they felt like was the most impactful. And they asked the same question of practitioners. Where do you get information? And it wasn't journal articles. It was professional associations, right? So where they're getting the information and where we're disseminating the information is two completely different places. It's a disconnect, right? Bronson, thank you. Yeah, I saw you pointing, and then I looked, and there it was. So part of the problem is we're not really using consumer input in thinking about how to develop interventions. Obviously, we've been for a long time not thinking about consumer input at all. So our studies just look at, does the treatment work? There's no evidence for the treatment. There's strong evidence for the treatment. But in fact, there's this whole dimension of how much consumers want the intervention that you developed, whether they like it, whether they're willing to come in every week for it, whether they have that kind of technology that delivers it. And so we start to think about that. Well, the ideal situation would be if consumers always really wanted the treatments that had the most evidence, right? And it doesn't work like that. It looks more like this, and we really haven't taken that into consideration. So what I've done to this point is bullet point one, providing you with this whole rationale, like we really need something new. We need new scientific methods. We need new ideas for figuring out this last little piece of translation, the D&I piece. What I'll do now is quickly define those terms, and then I'm going to talk briefly about key characteristics and challenges, and then I'll give the mic to Rob so he can tell you an example. So, in general, a definition of implementation research is one that introduces new practices or change in a way that gains traction and follow-through in the real world. And a study that looked at implementation would study whether or not the traction was there. So if you think back on the study that I was just showing earlier on the Family Checkup, old school, middle bridge type of research would ask, is this effective? Do kids who get the Family Checkup do better than kids who don't get the Family Checkup? Some maybe control group comparison. We're kind of taking some data on that, but that is not what we're super interested in. We're interested in reach. So out of all the kids in that clinic, and it's about 25% that exceed criteria for clinically significant psychosocial concerns, how many come in when they're invited to get the Family Checkup? And of those kids that come in, how many take advantage of both sessions, the assessment and feedback / treatment session, and how many take advantage of follow-up visits? So are we really reaching the population? What percentage, how deep are we getting? Another thing we're looking at is adoption. Are the medical providers, the pediatricians and the residents explaining the Family Checkup to their patients? When their patients score high on the screener, are they saying, I'm concerned about this. I think you need this, this intervention. We have this great thing. It's right here. Let me bring you down the hall and introduce you to folks. That's adoption. And we're also looking at variables like how high fidelity we use when we deploy the Family Checkup and whether or not the Family Checkup is sustainable in the long term. So will it pay for itself? Because the grant's going to run out, right? So are we going to be able to bill insurance for these services in the long run? And the money that we collect from insurance, is that worth it? How much time are we spending implementing this thing? Because if we're spending too much time and we're not collecting very much, then it's not necessarily cost effective. Value and cost effectiveness are huge factors here. Dissemination is really what spreading information around, how information about mental health care interventions is created, packaged, and transmitted, and interpreted among various stakeholder groups, so kind of a wider disbursement. Let me talk about key characteristics. So if you're thinking like, what makes it dissemination and implementation science? Well, one is a focus on stakeholders. So the first thing I did with my Family Checkup study, I did it on Tuesday. I met with the pediatricians, the public health people, the social worker, and the psychologists that work at ETSU Pediatrics. I brought lunch, and we sat down, and we talked about the family checkup. And what do you think about this? What do you think about using a different screener in your office? What space do we have? What are your ideas? Because this isn't going to work unless you all have huge buy-in. Focusing on stakeholders, which in our case is pediatricians, and we invited the office manager as well. In other cases, it's policy people or administrators. It's whoever it is. The other piece I mentioned earlier, engagement of transdisciplinary teams. So our team, as you saw in the video, has pediatrics, public health, and psychology. But I should just mention with transdisciplinary teams that people get very creative with this. So anthropologists be involved to go out and do get really rich data through interviews. So this is a very creative kind of engagement of lots of different expertise. I did a prior study where I was looking at stigma, and I had a stigma researcher on the team. So that was the translation of basic to clinical knowledge. So not just people that are clinical psychologists, but even expanding to basic researchers is important. Incorporating novel partners, so sort of entrepreneurial relationships. Some of my projects in theory, or at least in spirit, engaged digital media experts, because I really think like direct-to-consumer marketing and these things could play a big role in getting the family checkup more popular or having more parents be interested in getting it. So our team should have somebody that does advertising on it. And it turns out there's lots of people that do advertising that are very interested in how to do what they do for consumerist purposes, for healthcare purposes, and kind of the betterment of health. Another key characteristic is innovation and methodology. So we're moving outside of standard randomized controlled trials and other methods and moving into more unique study designs. I don't have time to get into, but there's entire study designs that are specific to D&I. And there's really a focus on moving quicker, not taking 7 years, rapid results, high risk, high rewards. And then this piece about scaling up and sustainability, like not starting a project without an eye toward, if this works, can it be used in a big scale way? So one of the big key challenges in this particular area is this problem of ex-novating, which I think is a great word, bad practices, like getting people to disseminating the right practices, the good practices, the evidence-based practices is one thing, but how do you get people to stop doing things that they shouldn't be doing? And that's a challenge. Getting rapid and practical results in just a couple of clinics is great, but then is that generalizable? So this is kind of one of the tensions within D&I science. This whole need for new methods, if we want to do this study, for example, sometimes, let's say public health department is rolling out a new program, there's an opportunity there to collect a bunch of data on whether their dissemination strategy works. And we now are starting to think about these as kind of maybe opportunities to do naturalistic studies, but you need a whole new method for that, right? Because we've never done naturalistic studies before. What represents the most rigorous naturalistic study that can be done? Another challenge is taking bets on technology, as I mentioned earlier. And the other challenge is fidelity versus adaptation. So a good example of this comes from the Family Checkup. The original version of the Family Checkup, which has tons of great data on it. It has great data for use with 4- and 5-year-olds, and it has great data for use with 12-year-olds in preventing substance abuse. It's done in 3 visits, 3 one-hour visits, with the middle visit being a home visit. That model doesn't work very well in primary care. We don't have that much time, and we also can't drive to people's houses. That's not what we do. And so making some adaptations to the Family Checkup, but also doing it in a way that remains sort of true to what core active ingredients are. The other problem in D&I science right now is that there are lots of people that are just working on up with new knowledge of how to do D&I science, which is great, except that it's not actually disseminating anything. It's just thinking about thinking. So we need people to go out and do studies and make an impact. I think that brings me to the place where I'm going to pass this off to Rob, but I just want to make one little editorial comment that I should have put a slide in on this. A lot of you are medical students and residents. Many of you are planning or already do have a very practice-oriented career where you're in the trenches, right? So you're doing work with real-world patients on the end point. You all are actually best positioned to do this type of research. Some of the best D&I studies that I did were before D&I existed, when I was primarily a clinician working in a rural pediatric practice. And I had an academic appointment, but I was there a couple days a week. And I collected data that was just part for the course. It was a lot of records review and stuff that was sort of permanent product data and our medical charts and stuff we had around the clinic. And I was able to show the uptake of an evidence-based approach to assessing for ADHD in that clinic. So, you know, folks like Rob and I that are really more in traditional academic jobs are almost at a disadvantage in D&I research in that we're not necessarily sort of well-versed in what's happening in the trenches. That's one of the reasons I really like to train my students and spend time in clinics, is because then I can get a better sense of where are the pain points and where can I get some traction with the stuff that I do. But I've sort of shifted my training with our graduate students, who are many of them oriented toward becoming clinical psychologists to do clinical work, to start thinking more about having an eye toward collecting data that might be, do it the right way, and they use the right methods, and they learn about some of the stuff that's coming out of D&I useful in a broader way, or a generalized way. Okay, I'm going to pass this to Rob so he can tell you all about, I'm going to turn this off.
How are you guys? Good to see you today. Thanks for the good turnout. It's fantastic. Oh, goodness, I have a problem. I'm going to tell you what it is. I had this set up to move forward on 15 seconds. So hold on one second, or to auto forward. So I'm going to mess around with this slideshow.
I'll run an interference.
Yeah, thanks.
Go to the D&I, when you go to Tighter, that training I was talking about, the assignment is to come prepared with 20 slides that move forward automatically on a 15-second interval. And the first day, you have to get up in front of a bunch of people and give a presentation while your slides are just automatically advancing.
Yeah, it's nerve-wracking.
Extremely stressful.
Yeah,
Do that today.
yeah, I've given hundreds of talks, and I talk about prescription drug abuse, which is what I'm going to talk about today, all the time. And I'm never really nervous, but in that setting with that auto forward thing, it was nerve-wracking. Okay, so I'm Rob Pack, professor of community behavioral health. I'm a prevention guy. Primary prevention is preventing something before it ever happens. My research area of expertise is prescription drug abuse, and I'm going to talk about that today. Since the mid-90s or so, there's been about a 400% increase in prescription of opioid pain medications, treatment admissions for addiction to opioid pain medications, and overdose deaths. It's a massive problem. I think almost everybody in the room is aware of it by now, and what you may not know, is that better? I don't want to shout at you guys too long. So what you may not know is that the U.S. consumes about 80% of the world's opioids. We're number one in the world, followed by anybody? Anybody? Canada? So we're number one in the world for prescription opioids being prescribed and used. We're actually, in Tennessee, we're number 2 in the number 1 country in the world. We are actually 1/10 of a percentage point off of Alabama, if you can believe that. And that amounts to is about 143.9 prescriptions for opioids every 100 people. So it's 1.43 scripts per person in Tennessee. That's data from 4th of July, MMWR. And East Tennessee is actually number 1 in the number 2 state. So if this is data from the Controlled Substances Monitoring Data base, and if you look over here in the legend on the right, these are prescriptions that are reported to the CSMD for benzos and opiates. So it's not exactly just opiates, but if you look at that, you can see that in East Tennessee, you have a particularly dense amount of prescriptions that are reported to the CSMD. Roughly 4 or 5 is the dark orange. The beige or orange is 3 to 4. Greater than 2 is the yellow. You can see that no one is really less than that, less than yellow, other than over in Memphis. So we have a massive amount of prescription benzos and pain meds going out into the population. Almost 10 billion morphine milligrams or equivalent dosing per year. So almost 10 billion MMEs dispensed. And this is in the 2018 Controlled Substances Monitoring Database. So what we actually have are a whole bunch of pills that have been prescribed. And what happens with these pills is there are people that get them, and then a few of them, and then they're in the cabinets. And so a lot of misuse of prescription opiates happens right out of the cabinets. In fact, teens will go in and take some, or maybe somebody is working at your house, goes in your cabinet and they take some out, and so there's a lot of diversion in that way. We have a massive amount of diversion. We are actually making some improvements in that through some policy means. We'll talk about that in a few moments. So this is just evidence to support that basically pills that are misused by teens, for example, they obtain them free from friends or relatives at about 2/3 of the time for amphetamines, tranquilizers, and prescription opiates. So if we're going to do something about this problem, these are past year non-medical users of pain relievers by age category. If we're going to do something about this problem, we're going to have to focus on preventing the problem over here, because really if you focus here, you're really almost missing the point, right? You want to do some work to kind of prevent the problem from occurring and attenuate this curve, or just sort of reduce the scale of the curve. And that's the goal of public health. That's the goal of primary prevention and our interprofessional efforts. Our philosophy, I guess, is that we can shrink prevalence. If you take the area inside the triangle as prevalence of prescription drug abuse or misuse, we can shrink the prevalence by shrinking the supply through things like control and diversion, through demand, things like treatment, which you guys are going to, if you're in psychiatry, psychology, you're going to be able to impact that, and then through potential and through primary prevention. So that's sort of our guiding philosophy. This is a busy slide, but stay with me for a second, because there's some important things to know here. If you take this as the continuum of addiction, if you will, dependence to addiction, from non-use to death, okay? I'm thinking specifically about prescription opiates and other drugs that are misused to the point where they might lead to death. There are many different kinds of effective interventions. Many, many things that have been proven to work. So we know that we can do good health professions training and continuing education. We're continuing to improve that mechanism. And if we take that effective CE and health professions training, we can impact this continuum at the primary prevention level. This is actually, this space from non-use kind of in here, you can get back over into non-use pretty quickly. If you think about it, kind of a reverse feedback here. The space inside the red is sort of the super danger zone. There's also other kinds of interventions that are effective. Screening, brief intervention, referral to treatment. You guys have heard of ESPERT. Does anybody have practice with Espert? No? Okay. We have a huge problem with neonatal abstinence syndrome, and we need to be treating the mothers and infants that are moms who are addicted to opiates and the babies who are actually born addicted to opiates. We need to be treating them in evidence-based ways, and that's really a third level of prevention, which is kind of rehabbing or getting them back to health. And we need to be preventing second pregnancy for those moms through use of long-acting reversible contraceptives. We've also got evidence-based drug courts, tons of evidence here that basically say that you can improve outcomes if you don't send people to jail where they learn how to be better criminals. Instead, you actually remand them to treatment, and then other things, right? Prescription monitoring programs and diversion control. This reduced doctor shopping by 56% in the past couple of years. And then we have medical-assisted therapy, and then overdose reversal with naloxone. This last one is getting a lot of attention in the media. So this is sort of our toolkit. We know that these things are effective. They're good, and it's going to take a comprehensive approach to get all of them moving and to do something about this problem. So if we know all these things, we know that primary prevention works, we should begin scaling up our effort. The reality is, I'm going to try to go back. The reality is, this one is getting a lot of attention, this one is getting a lot of attention, and this one is getting a lot of attention. All of these are actually in place because of a failure of primary prevention. A failure of primary prevention. We know that it works, though. We've got great evidence-based programs. We've got things like the parenting program, like the Family Checkup. The parental monitoring programs work. Authoritative parenting programs work. We know that parents need to be engaged. All of these things, so why don't we use them? Here's one of the most frustrating things. This website is the National Registry of Evidence-Based Programs and Practices. Read this right here. It's a searchable online registry of more than 300 interventions supporting mental health promotion, substance abuse prevention, and mental health and substance abuse treatment. These are evidence-based programs and practices. You can search this, and then you can come up with evidence-based programs right in front of you, and it even shows you where to get them. It'll split everything out by the population that it worked for. It's a fantastic site. These are evidence-based programs, and they're sitting out there. They've been designed and implemented by passionate people who take the program, take their time, take the program all the way to the mat. I mean, these are with great passion to develop great interventions. Unfortunately, a lot of times, as Jodi was talking about earlier, folks get engaged with this primary prevention work, and then they kind of move on to something else. It's so frustrating to get it disseminated or scaled up. And that's the goal of D&I, scale things up. So we proposed a project last year as part of a center grant proposal, and we're going to actually part and break it into a couple of different projects this year. But the idea is to strengthen families, strengthen youth parents and health to prevent prescription drug abuse. Our aims are to implement an evidence-based program and to demonstrate reach, effectiveness, adoption, implementation, and maintenance program, and then to develop a scalable dissemination strategy. So those were our aims. We're going to do this in areas of great need in the state. Just a couple of stats for you. In Sullivan County and Washington County, Sullivan County in the state is #1 for drug ER visits, #2 for treatment admission, #1 for drug poisonings, #6 for babies born dependent on opioids, and you can see the same for Washington County. We have in this region urgent need for primary prevention. Our innovation, part of our innovation, is, and it's one of the things that funding agencies look at is, how's your work going to be innovative? Our innovation is that we're really trying to recruit out of healthcare hotspots, trying to recruit out of all different kinds of healthcare settings to get people mapped onto an evidence-based program that Jodi talked about, the Family Checkup I'll discuss in. But the idea is that everywhere where there's a healthcare environment that we can recruit into this study, that we will begin to reach families that have the kind of kids we're looking for to get engaged with the work. And we'll also have the added benefit of being able to educate in the healthcare settings about the prescription drug abuse problem at the time. So this is our goal, is to get 1,000 dyads of parents and youth, and we have a pilot test of the mechanism now. So the intervention is a family checkup. Jodi talked about that earlier. It is an evidence-based program. There's also something called the Adolescent Transitions Program that's part of the family checkup, and this is, we do this in a place where it's natural and a good setting where people are going to be able to engage with the work. We're using what's called a re-aim focus, which is, since the work has already been demonstrated to be effective through clinical trials or randomized controlled trials, then what we want to do instead with our study is look at how much got engaged with the work, how much, what was our reach. We have to also continue to talk about effectiveness. How well did people adopt the strategies or the intervention? How closely was it put into practice in the way that the intervention creators intended, and then how well is it going to be sustained over time? That's the re-aim model, if you will. Part of the idea about dissemination and implementation science is you have a lot of flexibility and adaptation while you still use good scientific methods. And so the idea is that you have flexibility, but you also have rigor. So it's a little bit counterintuitive, but I guarantee you the methods are strong. So this is what's called a DAP, or Dynamic Adaptation Process. And it's a schematic that just that Dr. Polaha created that basically shows how the work is going to be adopted in the setting. And then just to kind of illustrate how the re-aim framework is used in a proposal or in a study design, these are some of the analytic framework tables that we put together to demonstrate how we're going to look at maintenance, for example, or effectiveness or reach, and have the outcomes listed, the analytic approach, and then the particular type of group that we're going to use to look at. So one of the great benefits of working in an academic health sciences center is you get to cast your net wide. You get to invite all kinds of partners in, and so we've got a large team that's had a lot of success over the past couple of years. The real benefit of doing this, though, is we also get to partner with the community. We have a vast network of community partners. We have over people on our email list. About 30 people show up at our monthly meetings, and we're beginning to get engaged in something called community-based participatory research, which is going to help drive this out into the community and further engage stakeholders. It's one of the hallmarks of dissemination and implementation science, and there's just a lot of energy around this topic right now. I want to invite you guys, by the way, if you're interested in the topic, just see me briefly afterwards, hand me a card or your email, and I'll get you on the email list. So there's a lot of pills in the mountains. There's a lot of risk for youth. We can do something about this. Jodi and I didn't intend to actually, go with the mountain theme, which is something that's nice about it from working here. But the idea is that over time we'll be able to do something to decrease out of the fog of all of this, all these opioids, and begin to return back to some of the clear ways of thinking. We can go back away from the overdose problem that we have and the tragedy of the desperate addiction that we see in our community. And anyway, I thank you for your time. I actually don't see a clock. Are we close to time right now? We have about 5 minutes left. That's great, because that's what we intended, and hopefully we'll have some questions. No questions? Professor Schacht.
How do you keep dissemination research from itself getting siloed?
Yeah, it's an interesting question. One of the things that I've been encouraged by is when I look at NIH, they actually have between National Institute, like for example, between NIDA and NIMH, they have between unit RFP. So multiple different funding units within the NIH. That's one way. So they're interdisciplinary. It is another discipline in science, though, and it becomes solid. But the intention is that it is it's interprofessional and interdisciplinary. That's one mechanism. Mm-hmm.
That organization already, so it's starting to become integrated into like traditional professional organizations that are very science oriented, like
To a greater extent, NCI is helping to drive this. So there are some groups that are beginning to drive the science toward this, and I think the key stakeholders at the NIH recognize it as something that is desirable, but it is a challenge.
One more question.
Sure.
If you look at the healthcare system as a whole, and you pay attention to the way in which it is skewed in favor of paying for fixing problems rather than preventing, does that set an upper limit on what you can expect to do with dissemination research? In other words, do we have to make some fundamental changes in our healthcare system before the full potential of this can be realized?
That's a very strong point. I'm going to take it as a point, not a question, because I actually I agree with you. I'm going to put a little spin on it. There's actually an enormous amount of money being made mitigating the prescription drug abuse problem. So if you add another vector, I mean, it really can grow the whole. We're actually fighting an uphill battle against pharma industry and other types of healthcare. Because there's money being made propagating the problem there as well. Think about pain and so on. So it's a little bit of a spin on your comment, but I do agree with what you're saying.
like applications of science public policy itself.
Oh.
They're like they're reading the conceptualize with disseminated out into like public health sectors and policy change isn't necessarily a clinic or a specific health.
That's a good example of that in this work is the implementation of the Controlled Substances Monitoring Database. That is a policy level change that's had an impact on the supply side of abusable narcotics. Other comments or questions? Actually, that's a great question. We're mostly concerned with prescription drugs, and in particular, we really focus on prescription opiates. Although we're beginning to think about prescription stimulants and misuse of prescription stimulants. And there's a new RFP actually that's doing. The proposal is due in November. We're thinking seriously about applying for that because we have a new fellow that's got some history in this area doing research in this area. So we may be able to put together a decent team on it. But really, right now we're thinking, Schedule 4, 3, and 2 narcotics.
I'm only asking that. I'm actually giving a greater understanding on
Mm-hmm.
addressing what I see as a growing trend of an increase in non-controlled substances, namely antidepressants.
Okay.
And a few of the other antipsychotics that are.
Really?
I would be interested to know what your take on the misuse, I guess the growing trend of the misuse of non-controlled substances is.
I can't. I don't have a deep expertise in the area. I will tell you that there are some non-controlled or more lightly controlled substances that are used to potentiate the effects of stronger narcotics. For example, many addicts will use soma alongside a prescription opioid. So there is some of that happening. One of the main problems that I guess the second most prescribed drug in the state is actually it's a benzo. There's another group of folks that are really working on benzos, and that's kind of a different area of study. But it's a good illustration of Dr. Schock's point, which is if you begin to do that, you begin to silo even this work. So it's an interesting point. I think I haven't been paying as much attention to it. I will begin to. Thank you for bringing my attention. Other thoughts, comments? Well, thanks for your attention. Jodi?